Wow. Hour 20 and good afternoon, I guess, for you, or just noontime.
It's noontime.
I am so delighted to welcome you, Birgit, and to hand the hosting baton over to you. For those who don't know, Birgit Poniatowski is the executive director of the International AIDS Society, and I have the great privilege of being on the governing council of the IAS and being able to work so closely with you, Birgit, and the secretariat in convening the community science, policy, and advocacy, as you always say, bringing us together. And over to you to take us 1 hour closer to the end of the marathon.
Thanks a lot, Mitchell, and I'm so happy to be part of this live stream. I wish I were still able to hang in there for 24 hours without sleep. It was really difficult to leave the live stream last night, but unfortunately, I've reached the age where I can't do that anymore. So. Yes, good morning, good afternoon, good evening to all of you wherever you are. Welcome to our 24 hours to save AIDS research. As Mitchell so kindly introduced me, I'm Birgit Poniatowski and with the International AIDS Society, an organization that operates globally, and we bring together science, policy, and activism because it's only when we work together that progress happens, as we have heard so clearly during the previous hour. Now, during the next 60 minutes, we will hear from leading researchers concerned about bringing the exciting technologies that we have at our disposal to the people who need them, the people who are sometimes called hard to reach. And what an upside down concept that is, because it is the services that are hard to reach for people that are the problem, not the other way around. And we will also hear about African leadership in HIV science. So without further ado, I'm very happy to call to the stage Sarah Stutterheim. She is an associate professor at Maastricht University's Care and Public Health Institute and a specialist in the psychosocial aspects of HIV, who will address that persistent barrier for people to access HIV prevention and treatment services, Stigma. Over to you, Sarah.
Thank you, Birgit, and thanks to the organizers for the invite. Now, StreamYard is new to me, so I'm going to see if I can actually get this to work. Is this me doing that? Or is somebody else doing it for me? Okay, let's see. And let's see how I navigate these. All right, so my talk today is focused on why addressing HIV stigma should be our #1 priority in the HIV response. And in doing that, I want to quickly outline what stigma is. Stigma is a concept originating in sociology, but also applied in social psychology, where a person is socially and culturally described as being different. And this leads to subsequent devaluation and status loss and discrimination. So stigma is something that has to happen in social contexts, in interactions between people, and it requires the exercise of power to function. According to our colleagues Violette and Lincoln and Dovideo, stigma has 3 functions. Oh, the animations don't work. Okay, so the first, and you'll see that off to the left of the screen, is that stigma functions to keep people in through norm enforcement. The second is to keep people down through domination or exploitation. And the third is to keep people out through disease avoidance. And what I want to do is talk quickly through the various types of stigma that are out there. So this is a model developed by my colleagues, Ariane Boss, John Pryor, and Glenn Reeder, and myself. And basically, we posit that there are 4 types of interlinking stigma. The first is public stigma. That's what's out there in the world. That's what people think about HIV and about people living with HIV. And it's basically the things that are happening in their brain in terms of what they think in terms of people with HIV. Then we also have self-stigma, and self-stigma has 2 components. One is the fear of negative reactions from others, and the second is the internalization of those negative beliefs about HIV and living with HIV. Then we have stigma by association. That's the stigma experienced and anticipated by people that are in some way connected to somebody with a stigmatized condition like HIV. And then I think you can think here about the buddies back in the early years and healthcare providers that provide HIV care in contexts where HIV is highly stigmatized. And the last, and I think this is a very important one in our current day and age, is structural stigma. And structural stigma is the stigma that's embedded in our policies, in our institutions, in our legislation, and in our funding cuts. So when we look at HIV stigma, we can basically say that stigma is built up of thoughts in the form of stereotypes, emotions in the form of prejudice, and behavior that manifests as discrimination. And if we look at HIV stigma, what we see is that there's a number of beliefs that underlie stigmatization. One is that it's super easy to get HIV, which we know isn't the case. Two is the idea that HIV is a very severe condition to have. So when we see we're still paying penance for what was done in the early years in terms of the prevention messages that really painted a very severe picture of HIV. So if people believe that it's easy to get HIV and you'll inevitably die of it, then the likelihood of stigmatization is also much higher. The third aspect or stereotype that contributes to HIV stigma is this notion of perceived responsibility. So when we attribute blame or we consider people to be responsible for the acquisition of HIV, then we're also more likely to stigmatize. And the last component under stereotypes or cognitions that drive stigma is this notion of norm violation. Now, HIV has this reputation of being connected to a number of behaviors that some people aren't too big of a fan of. So when we have high levels of homonegativity, then we're also more likely to stigmatize people with HIV. So HIV's connection with sex work, with sex between multiple partners, with sex between men, with substance use has all contributed to HIV stigma. It layers over top of each other. There are these various degrees of marginalization that come together. And these thoughts or stereotypes about HIV, they lead to an emotional or an affective response. And what we see is when perceived contagiousness is high and perceived severity is high, there's a fear response that comes into play. And we'll see stuff like avoidance as the form of discrimination that plays out from that. When we have high levels of perceived responsibility and we see HIV as being associated with things that violate our norms, then we're inclined to respond with greater anger and less compassion. So this is kind of like the backbone of how HIV stigma works. And HIV stigma can be both really manifest, like explicit avoidance or blame, but it can also be really subtle. So it can take the form of awkward social interactions with healthcare providers that are feeling uncomfortable. And in addition to having multiple different manifestations of HIV stigma, we also know that HIV stigma happens across tons of contexts. So in the close context, the interpersonal context with friends and family, but also in organizational contexts like with schools and work. And we also see them in our healthcare institutions. It's a big problem, HIV stigma in healthcare institutions. And we also see more broadly in society in the way that media represents HIV. So these various layers of stigma and the various forms of stigma happen in a number of contexts, which makes it a complex thing to address. Now, in addition to having significant impacts on both psychological well-being and social interactions, stigma isn't very good for the what we call the HIV care cascade. So the cascade is built up of prevention and testing, followed by linkage to care. What happens then is treatment initiation, adherence, viral suppression, and quality of life. And stigma negatively impacts all aspects of the cascade. And I want to talk briefly through these various aspects. If we look at prevention and testing, the research shows, it's not clicking through. The research shows that perceived experience and internalized stigma negatively impact attitudes towards condoms, the intention to use condoms, and actual condom use behavior. And when we look at PrEP, the research shows that HIV stigma as well as PrEP stigma impact initiation of PrEP use as well as retention and adherence. And it is particularly the anticipated stigma that leads to non-disclosure of PrEP use. And this isn't unjustified because the research also shows us that disclosure of PrEP use has been found to loop back and generate HIV stigma. Stigma is also a fundamental barrier to testing, particularly when it occurs in healthcare settings, and the relationship goes both ways. More stigma leads to less testing, and less stigma leads to more testing. Stigma also impacts linkage to care, treatment initiation, and treatment adherence, which ultimately impacts viral suppression. And what we see here in terms of linkage to care is that the research shows that anticipated, perceived, internalized, and enacted stigma impact both engagement and retention in care. And again, here we see that stigma in healthcare is a serious issue. Now, when it comes to initiation and adherence, there's a small body of literature that links stigma to people not initiating treatment. And there's a much larger body of literature that links to adherence. And when we look at the literature on ART adherence, what we generally see is that the impact of HIV stigma on adherence flows through psychological factors like mental health difficulties, self-efficacy, and you can't see it there, but it should be there, disclosure concerns. Now, the last thing I really want to talk about, this is the cascade proper. The last thing I want to talk about is also stigma's impact on quality of life. Quality of life is a really broad concept, but it generally includes a number of psychosocial aspects of HIV. And I want to show you a little bit of research that our team has done in this regard. This is a study by my colleague. This is a study that I led, And I want to show you here that we found that public stigma is positively related to psychological distress, namely depression and anxiety, and negatively related to positive affect and social support. And then this is a study that I initially had in mind from my colleague Ivona von der Kooi, showing that perceived public stigma and experienced stigma have detrimental impacts on quality of life through internalized stigma. And these are just two examples. There's lots of literature out there. So clearly, stigma negatively impacts the entire cascade and quality of life, but I wouldn't want to leave you hanging with just a negative message. There's stuff that we can do. So what I want to talk really briefly about is how we effectively address stigma. Now, I'm going to bring this back on your radar that we have public stigma, self-stigma, stigma by association, and structural stigma. And I want to talk about the various ways in which we can address these forms of stigma. Now, if we're talking about reducing public stigma, so the stigma that's out there in the world and that happens in our interactions, there are a couple of fundamental things that we can do. The first is to increase HIV knowledge, but I want to say very clearly here that knowledge is only a first and fundamental step. Knowledge doesn't actually change stigmatizing attitudes, because people can know not to stigmatize, or they can know about you as you, but it doesn't necessarily mean that they feel it in their bones. And I think that's really important. And so if we provide adequate HIV knowledge and have improved that, we also need to support those interventions with opportunities for interpersonal contact, because only when people have experience and familiarity with people with HIV, either in person or virtually, or by listening to this live stream today, only then does that humanize the living with HIV. And these opportunities for interpersonal contact are really key at inducing empathy. Empathy is a really solid strategy for reducing HIV stigma. And I think beyond HIV stigma, empathy is what our world needs most right now, today, in our current socio-political context. And what empathy does really well at is encouraging perspective taking. So I don't know how many of you were told, if you had siblings when you were young, that, and you hit your sibling, for example, that your parents would say, how would you feel if he did that to you? The real question that we should be asking is, how do you think that person feels when this happens? And so in the context of HIV stigma and our efforts to reduce it, what we really should be doing is encouraging people to think about the impact of negative reactions to people with HIV, because then they can envision what kinds of impacts that have, and it creates an empathic response. So these are the 4 key things that I think we should be focusing on in reducing public stigma. Now, when we talk about reducing self-stigma, this is the internalization or anticipation of negative beliefs or reactions from other people. There are also 4 things that I would recommend. One is to plan coping responses. Not everybody is going to respond in a positive way, and having empowerment and resilience built in to cope adequately with negative reactions is really key to strengthening our communities. And in that sense, the focus on building resilience and empowerment is really, really key. The HIV field is very much marked by nothing about us without us, and I think this is really paramount in terms of ownership and in terms of building that resilience. A third strategy is to improve psychological flexibility to navigate disclosure contexts where it could be positive or ambivalent or negative. And I think what's really fundamental is that we provide support to our HIV communities to navigate experiences with stigma, and also in terms of confronting stigmatizing and discrimination. Now, in terms of reducing structural stigma, there's a few things we need to do. We first need to adjust our social norms in the direction of greater inclusivity and appreciation of diversity. We need to revise our policies and legislations to ensure that they are non-discriminatory, and I think we can work very strongly with media to convey non-stigmatizing messages. All too often you see words out there that we don't want to see. So I'm going to wrap up really quickly with a conclusion, and this is it. We know that stigma is a problem. We have tools to reduce stigma. We're doing a lot. We're using evidence-based approaches, and when we do, they tend to be more effective. And now is the time to intensify our collaboration, scale up the work that we're doing, and work systematically. And to do that, we need to continue to be doing HIV research. Thank you.
Thank you so much, Sarah. That was a very clear presentation, and thank you also so much for ending on what we can actually do about it. We've been talking about stigma for so long, and it's still there. And what I was, before moving to comments from and questions from others, I was wondering, do we have any insights, learnings from other disease area where certain elements that you mentioned, for example, the responsibility part, I'm thinking about some NCDs, for example, where that also comes in, maybe not the fear of transmission, because it may not be an infectious disease, but do we have any learnings? Do we see any differences? Actually, because in many times we're talking about service delivery providers, who are at the very kind of end of the chain there. What are your thoughts about that?
Yeah, so there's quite a bit of research out there on different conditions and identity that are exposed to stigma. We have a really robust literature in HIV, but there's also a monstrous literature in the mental health space. And we also see stuff in regards to discrimination against people who use substances. And for all of these, the stereotypes that underlie the negative emotional reactions and subsequent discrimination can vary a bit. So this aspect of perceived responsibility is often placed on people with substance use dependence, that they're responsible for having started using drugs, and they're also responsible for stopping that use. When you look at dependence, that's not a personal choice often. In the mental health space, we also see different things that drive it. Sometimes people with mental health difficulties are considered unpredictable or dangerous, and that will drive a fear response. So, well, the underlying stereotypes are different across conditions. There's a lot to be learned in terms of how to effectively navigate them. And in the mental health space, there's a lot that has been done in terms of effective interventions. In the intervention that I'm involved in called Reset, which promotes resilience and empowerment, we've drawn also from work on the Honest, Open, and Proud program for the reduction of mental health stigma. And so the methods that work for tweaking stigma carry across the board. It's the stereotypes that underlie the stigma that vary per condition or identity.
Thanks so much. I see that we need to move on. So We are gathering all the comments. They won't be lost. Thank you so much, Sarah, for this very enlightening presentation. And now, before moving on to our next speaker, we have a testimonial from Myla Lyons.
Hi, I'm Myla, and HIV research needs to be saved because Black women's lives matter, as do Black and Latino men's lives, trans women's lives, and the lives of people who are using drugs. All of these population groups have unmet needs in HIV prevention and care. I am a doctoral student of applied social psychology, and as a Black woman, learning that there is a science behind Black women's inequitable acquisition and HIV-related complications inspired me to become a scientist to reduce these inequities by individual-level interventions and, more impactfully, structural-level interventions. Science and its scientists cannot sit idly by or turn a blind eye as HIV continues to be a health crisis.
That was a very powerful statement and a good segue to our next speaker, in the sense that it is so good to see that people continue to be motivated to dedicate their lives to HIV research. And we have one of those people here with us today, Nyaradzo. Very nice to see you. Nyaradzo Mgodi is a senior researcher at the University of Zimbabwe Clinical Trials Research Center. As many of you know, Nyaradzo is a leader in clinical trials for biomedical HIV prevention, and she will talk to us today about an African-led research agenda for HIV prevention in women. Over to you, Nyaradzo.
Thank you so much. Please confirm you can hear me, Birgit?
Yes.
Oh, perfect. And thank you to the organizers for inviting me. And I just loved the testimonial. I think it sums, like you said, it sums my presentation up. We really must not forget the Black woman, but I'll go beyond the Black woman and I'll talk about the African woman and what is it that we can do to have an Afrocentric scientific agenda for HIV prevention in African women. Someone might ask, why African women? I think over the 24 hours, we've heard, the past 24 hours, we've heard how us African women continue to face intersecting syndemic conditions. I think Connie Killam yesterday spoke about STIs. So STIs, unintended pregnancies, gender-based violence, mental health challenges. We've just heard about mental health, food insecurity, migration, and many other comorbidities. So women, we really need to be looked after in terms of HIV prevention. We have an unmet need for contraception. We know that sub-Saharan Africa bears the highest proportion of women with unmet need for contraception. Nearly a quarter of women of reproductive age in my region here in sub-Saharan Africa, we fall in this region. As a result, there are unsafe pregnancy terminations, abortion rates in the region, and women suffer from comorbidities related to illegal termination of pregnancy. When you look at, there are many reasons for unmet need for contraception. I'll not dwell into that for the sake of time. Coming on to another intersecting epidemic, STIs in women. The prevalence of STIs in African women remains alarmingly high. We know that STIs increase the risk of HIV acquisition. The WHO estimates a daily global incidence of 1 million STIs. So when this webinar started, which was like 5 p.m. my time, 21 hours ago, by the end of it, 1 million people would have acquired STIs, and 40% of those will be in sub-Saharan Africa here. And the vast majority of those will be in women in sub-Saharan Africa, and mainly in women 15 to 49 years of age. Regrettably, about 30% of sexually transmitted infections are in women, and there are they are asymptomatic, and this may lead to many sequelae, including increased incidence of HIV. I talked about HIV, subfertility, ectopic pregnancies, birth defects, stillbirths, and many, many, many other conditions without women ever knowing that they had an STI. And besides these physiologic detrimental effects of STIs, there are also psychological and economic effects of STIs in women. And we as African women, we also suffer from violence. There's physical violence, sexual violence, emotional abuse. To the left of the panel, this is the Eswatini FACT study, which showed that 25% of adolescent girls and young women experienced violence against them by the time they were 18 years of age. And to the right of the slide is the study in Zimbabwe, which shows that the type of violence can be mixed. It can be emotional, sexual, physical, and emotional, sexual and emotional, all mixed types of violence. So we really need to ensure that women are taken care of. This is a slightly old slide, but it doesn't change the message that the burden of HIV remains high in women. I think Linda Gale, LGB, spoke earlier on about the number of young women who are going to get HIV in the next hour, in the next day, or in the next month. So the numbers of HIV in women, they remain high. So, and I think Linda Gilbecker talked about HIV prevention here. We know that condoms, HIV testing, partner testing and treatment, they all work. And STI treatment also works to prevent HIV. But we've talked a lot about PrEP. We've talked about oral PrEP, lenacapavir, the new kid on the block, the dapivirine vaginal ring, long-acting cabotegravir. All those work, and work is in progress to look at MPTs, BNABs, and MK8527, which I'll talk about in a jiffy. So all these HIV prevention methods, they work. Also behavior change and condom use, they work. But we know that daily oral PrEP, the dapivirine vaginal ring, cabotegravir, and lenacapavir will not address the needs of all people who need HIV prevention. So there's need for products which are less costly, which are more acceptable, which provide added value and have less impact on health systems in low and middle income countries like mine. We need products that women can control. We need products that will cover the needs of women. We need a one-stop shop, something that will cover the intersecting syndemics that I talked about, that will deal with stigma. We heard about stigma, that will deal with preventing violence, something which is discreet and something which will prevent STIs, HIV, pregnancies, all in one. So that is what we need. And MPTs may have added value for users, multi-purpose prevention technologies. I'll talk briefly about MK8527, which is the new kid on the block, which is being researched by Merck MSD colleagues. They are going to be looking at this monthly oral pill for HIV prevention in cisgender women and other non-binary populations. And already their protocol 10 and protocol 11, they are almost starting, or they've already starting. I'll not dwell a lot on this new oral monthly pill, and we know that our work has already also commenced on the silicone implant, that's Caprisa 018, just to let you know that there are many, there's a lot of work being done to assist in HIV prevention in women. Multi-purpose prevention technologies in development. So this is variable. So apologies if things have changed in the past day, a week or so, but to date, there were 21 products in development, intravaginal rings, gels, inserts, films, injectables, and so forth. So I'll talk a bit about some of these technologies. I'm just checking my time. And Birgit, please feel free to let me know when my time runs out, because I cannot see my time on the screen. So next slide. So I just want to delve a bit about Matrix, because I want to talk about Afrocentric research for Africans by Africans. So Matrix was a USAID project to advance the research and development of innovative HIV prevention products for women. And we had a primary focus on early research and development. And this was through a North-South partnership to develop a wide range of HIV dual prevention products for women. So these were the product pipelines. These were the products that we had in the pipeline in January 2025, prior to the stop work orders, with the TAF first developing insert, dapivirine vaginal film, the dapivirine levonorgestrel dual purpose vaginal film, and the non-ARV, non-hormonal contraceptive dual purpose vaginal ring. So what is the TAF EVG insert? This is a dual compartment. So I love talking about women, but also we mustn't leave anyone behind. So for those who are going to acquire, who may acquire HIV through the back door, this would also be a useful insert. So it is used for its user controlled, it's flexible, and can be on demand for HIV prophylaxis. So it deals away with stigma. It deals away with many other challenges that women experience in terms of HIV prevention. And why would we work on a TAF EVG insert? How is it any different from existing approved PrEP products? It would provide a new PrEP option, fewer doses, fewer side effects, and it will be against HSV2 as well as HIV. Sorry, I don't know what is happening with my slides. All righty. Also, I wanted to remind people about the 30-day film. This is a monthly alternative to the ring, the Pivrin ring.
Apologies. You asked for a reminder of time. This is one.
Yes.
We only
How
have
many
a
minutes?
few minutes left if you want to give our viewers a chance to actually speak with you.
Sure, thank you. So yes, I was already done. So I was going to talk about the ring, which has got several advantages. And Matrix was unique in that we worked with African women for products that will work for them. So really, I think it's been said by everyone, the R&D pipeline that is in that is there for prevention technologies for women, we need additional investment to move these products forward. And I'm happy that Zimbabwe, we are doing our bit to ensure that domestic funding is there. And I'll say thank you here so that we can have a discussion. Thank you, Birgit. Over to you.
Thank you so much, Nyaradzo. And I know there you have a lot more to say, and sorry about needing to cut you short, but I'm sure we have some questions and comments from our audience. Before we get there, though, just let me say that your presentation again demonstrated that we have to, and we do it, but other people as well need to move away from thinking in individual diseases and individual technologies, but turn the perspective around and start from the person and what a person needs at different times in their lives. Otherwise, you know, the numbers you showed from the 2023 UN AIDS report, they were pretty much still correct because so little changed in 2024, other than obviously, the number of people living with HIV has gone up because new acquisitions haven't gone down a bit. So really the work's not done yet. Do we have any comments or questions from our, there you go. What about DoxyPEP?
Sure. Thank you so much, Lorenzo. Great question. So yes, I talked a bit about, and I will talk about DoxyPrep for now. I talked a bit about the TAF EVG insert, and the plan was that this TAF EVG, TAF elvitegravir insert would also be used combined with doxycycline. So the hope was that this would be a TED, TAF, EVG, doxycycline insert for pre-exposure prophylaxis. So we know that DoxyPEP works in populations, MSM, and more work is needed for women, cisgender women. So it is an important topic for discussion, and funding permitting, we really must continue looking at doxycycline, DoxyPEP, and PrEP for women in Africa. Thank you so much, Lorenzo.
And Jim has a question, how we maintain a robust pipeline for options that are not long-acting and systemic. Very important question, because so much attention now seems to be on long and longer-acting options.
Sure. Thank you, Jim, for that question. And do not get me wrong, I'm a proponent of long-acting injectables. I worked on KBLA, and really I loved how Purpose 1 and 2 were done, and I'm happy that we do have these long-acting injectables. But like I said, we need choices. Women need choices. We've learned from the contraceptive field that the more choice you give to someone, the better the uptake, the adherence, the continuation, the persistence. We know that in contraception, the more choices you have, the better the outcome. So this is what we need for HIV prevention. I administer injections on a daily basis in my clinic, but you could never give me the injectable. So I need something that I can work with. I need something which is topical, which is reversible, which will prevent multiple conditions. So we need to continue working on non-systemic, shorter acting on-demand products, because they will work for certain populations, and we want to give them choice and options for what they can use, what will work for them. So thank you so much, Gift. Thank you so much, Jim, for that question. Very appropriate, and we need sponsorship, we need funding for some of these products. Thank you.
Absolutely, and then maybe to just kind of add on to that, you're saying some options work for different populations and for individuals within populations, because what you do and don't want to put in your body, that also is not just influenced by the group you identify with or the background you have. So. Yes, do we have another question? We have time for one more before moving on.
Margaret.
Yes, absolutely. Women must have control. Who can take issue with that?
Thank you so much, Margaret, for that. And we're still hoping, and perhaps why I talked about this, I just wanted to update the panel, our audience, that our leadership in Matrix, of which I was part, we continue looking for sponsorship to finish off the work, the important work that we started. And thank you, Margaret, for bringing this up. And I must say that we are starting to analyze our specimens from Matrix 002, looking at the vaginal film which was done in Matrix 002. And very soon, hopefully, we'll be able to share our results and also to publish the findings. This work must not stop. This is a minor setback. In a war, there are many battles. It could be that we've lost this battle, but at the end of the war, we will win the war against HIV. So thank you, Margaret, for bringing that up.
And thank you, Nyaradzo, for putting it so aptly that, yes, this is the resilience, right, that we have seen so many times, time and again in the HIV response. So thank you so much. I'm now moving on to our next and final speaker in this hour, and I'm happy to introduce Lauren Violette, and I hope I did say your last name correctly. Lauren is an epidemiologist who is a research fellow in the Department of Population Health at Harvard Medical School, and she will talk to us about a very important aspect of making services reachable for people, which is demedicalizing the provision of PrEP access as well. So over to you, Lauren.
Thank you so much. Okay, so today I want to talk about a potential new strategy for PrEP delivery, and that is over-the-counter availability of oral HIV PrEP. So this idea was largely inspired by years of work done by researchers and advocates in the reproductive health space. In July of 2023, the first oral contraceptive was approved by the US FDA for over-the-counter use. So my question to you all today is, why not PrEP too? Since its introduction, PrEP use has increased across the United States, as indicated by this graph here that shows a 4-year period of time. This is by all means a public health success, but there's still a lot of room for improvement. In 2022, there are almost 38,000 cases of HIV diagnosed in the United States, and it was estimated that of the 1.2 million people likely to benefit from PrEP, only about a third had a prescription for the medication. Many people who are not on PrEP cite barriers to access as major issues for uptake and use. These include, but are certainly not limited to, frequent clinical visits and laboratory monitoring, which can be inconvenient, especially for folks who are employed, who are living in rural areas, or are struggling with other needs. System complexity and trying to navigate insurance or patient assistance programs. And fear of stigma and discrimination that comes with people needing to ask their providers for PrEP, which is supported by data on racial and sexuality biases in PrEP prescribing. We hypothesize that these access-related barriers to PrEP will only be exacerbated by recent and proposed cuts to U.S. Health and Human Services programs and staff, public insurance programs, and HIV research funding and infrastructure. So in settings where health systems underserve vulnerable populations, the World Health Organization recommends self-care interventions, things like over-the-counter oral contraceptives and HIV self-testing, in order to improve health coverage. And this is especially true in instances of major disruptions to the healthcare system. We believe that this time calls for new delivery strategies that could both preserve and expand PrEP access and truly simplify care. So we ultimately just need to make it easier for people to get on PrEP and to stay on PrEP. One possible avenue for this could be making PrEP available over the counter. So this would be true over-the-counter access without the requirement to see a provider, get laboratory testing, get a prescription, and have that prescription filled. OTC availability would eliminate the need for people to disclose behaviors to clinicians, which would ease access for everybody, but particularly for populations experiencing stigma and discrimination in healthcare settings. There's potential for expanded, more equitable access beyond the traditional spaces that offer HIV prevention to areas where there are not providers prescribing PrEP. If it was paired with thoughtful marketing and educational campaigns, OTC availability could increase demand among priority populations who have unmet needs for PrEP. And without this need to interface with a provider or a pharmacist, OTC access could facilitate distribution through community-based organizations where people feel comfortable, but can still maintain a touch point for the supports that they might want or need. And then finally, just having a bottle of PrEP on a shelf next to condoms or Tylenol, for example, could help normalize PrEP as a self-care tool and increase autonomy. So while this innovative strategy has potential implications on things like access and use and impact, we have to learn more about what this might look like to get FDA approval for over-the-counter use and how it might be scaled up if it were found to be safe and effective. So as part of an NIH-funded project, we surveyed 3 national cohorts of populations likely to benefit from the protection that PrEP provides. We asked if research showed that using daily oral PrEP without a prescription was safe and effective, would you support making daily oral PrEP available at a pharmacy or online as an over-the-counter product? We found that support was high, ranging from 83% in a sample of gay and bisexual men and a sample of cisgender women to 87% among a sample of trans women and trans feminine non-binary people. Among the latter group, we found near universal support for OTC PrEP among those who worried about stigma in healthcare settings or their privacy while insured on a parent's health plan. Among a US sample of gay and bisexual men, 81% had any interest in using over-the-counter PrEP for themselves, with about half very interested in this delivery option. We asked about reasons for interest in use, and note here that these won't sum to 100 because people could endorse more than one reason. But we found that people liked not having to schedule or attend appointments. About half thought it would be faster than getting PrEP through a provider. And people appreciated the fact that over-the-counter might be more private than having to discuss their sex life with a provider and get a prescription for PrEP following that interaction. We also asked about reasons for not wanting OTC PrEP. About a third said that getting PrEP allows them to access some of those wraparound services like STI testing when they're already seeing a provider. There were concerns about cost, about efficacy of an OTC option compared to prescription PrEP, and other safety concerns. So because an OTC model would give more people choice about how and when to test for HIV and STIs, we wanted to understand what folks' testing plans would be if they decided to choose OTC PrEP. Respondents said that they would access testing through a provider, whether that's a primary care provider, a sexual health clinic, self-testing kits, and other ways, or a combination of these things. I think the takeaway here, though, is that only 3% indicated that they would not access HIV or STI testing if they were using OTC PrEP. So almost everybody had some sort of testing plan in place. So we've also conducted in-depth interviews with different stakeholder groups to understand perspectives on over-the-counter PrEP. We've chatted with clinicians and advocates, public health officials, industry reps, policymakers, and potential OTC PrEP consumers. And there's been a general consensus that OTC availability of PrEP could have a net positive impact on access and on stigma reduction. So this first quote here highlights the fact that OTC availability could engage a population of people who don't like going to the places that do the majority of PrEP prescribing. So a provider or engaging in a healthcare system. This person highlights the fact that many places in the United States don't have practicing infectious disease doctors who likely do the majority of PrEP prescribing. They said that there are big geographic differences, but that all of those counties do have a pharmacy. It's not mentioned here, but OTC availability would also open up an avenue for getting PrEP online, which could expand reach even more. Many people hypothesized that OTC availability might move the needle when it comes to PrEP-related stigma. So this person here says that OTC allows people to do a late night run, time it properly, grab what they need from a pharmacy that isn't in their community so that nobody's in their business. There is a balance to this, though, and we wanted to understand what some of the potential harms might be. So with more relaxed clinical monitoring, there could be implications for HIV drug resistance if people aren't testing themselves for HIV before starting on OTC PrEP. There might be other safety concerns, renal toxicity issues, hepatitis B flares, or bone impacts that result from using PrEP with reduced monitoring. And then people are also concerned about STI incidents. You know, one of the really nice parts about PrEP care are the wraparound services that people are able to receive when they have a regular touch point with the healthcare system and with a provider. And included in that is STI testing and treatment. So interviewees suggested things like distribution through community-based orgs to maintain those wraparound supports, pairing OTC PrEP with HIV or STI self-tests. So maybe they're packaged together, they're next to each other on the shelf, or pairing OTC PrEP with some sort of tech component that might connect people to local testing sites. I think the most salient theme, though, was that we need to consider how we introduce, market, and roll out OTC PrEP so that we don't worsen the inequities that already exist in PrEP care. One interviewee said, it just feels like every new innovation, there's certain people, white, educated, affluent people, that benefit the most and everyone else is left behind. Is an innovative thing like this just going to exacerbate inequities versus help overcome them? But I also think that we can't be afraid of innovation. We have to just figure out how to overcome these inequities as we move forward. So there is a very long and detailed roadmap for getting FDA approval for switching a medication from prescription to over-the-counter. The ultimate goal, though, is to figure out if populations likely to benefit from PrEP are able to use OTC PrEP safely and effectively. So this requires conducting studies to figure out how people might want to access it, what a label might look like, and if people can read and understand that label and, you know, properly decide when to take PrEP or when not to take PrEP. And then also look into other safety outcomes. And all of this requires support, both funding and also the building of a coalition of community members and researchers and advocates and providers and other stakeholders to really champion these efforts. All of the studies that I've highlighted today, so the original NIH grant and the grant supporting the 3 national cohort studies, they were all partially or completely terminated earlier this year. Some have been recently reinstated, but so much uncertainty still remains. And as we think about advancing the field, or even just trying to preserve what we have, we need to push for more innovative, self-managed models of care delivery that can withstand these types of policy changes in order to ensure uninterrupted access to HIV prevention for all who may benefit. And I wanted to close with a quote from one of our participants who summarized this all quite nicely. They said, I think there's going to be much less access to healthcare across the board. When people don't have access or when providers aren't able to give access the way they used to, or there's fear around supporting patient access, I think that makes having community access even more important. Systems are going to break down and we need to meet people where they're at, and for that to be a new way of thinking about healthcare. This will be a challenge, but if there's a way to get through it and to expand access, it'll set up communities better for having direct access to things that allow them to care for their own health. So on behalf of my colleagues and collaborators, I want to thank you for the opportunity to share our work today.
Thank you so much, Lauren. And what a plea for continued research support. You've highlighted not just what we know and what the opportunities are, but in order to find the right ways that support self-care, but also, yes, don't take away that aspect, of what you call wraparound care, or some people call integration. There's a lot that is still not understood, and we do need continued science support to be able to understand it. So with that, I'm opening up for comments, and there we have the first one from Lorenzo. Do you believe we could get as progressive in the US and provide some HIV services through vending machines? This is happening in Brazil.
Yeah, I think that would be the goal, right? I know that, we do have some of that happening as far as harm reduction in the United States, but I think something like making PrEP over the counter would make that much easier, right? And again, you'd be able to go into a CBO and feel safe and be able to access a vending machine that way. So I think that would be the ultimate goal. I think that, one step towards that would to be getting access or getting approval for over-the-counter PrEP.
Absolutely, and if I remember correctly, the system in Brazil, I mean, initiation is with a provider, but then access to the product subsequently and testing, etc., that happens through the vending machine. Jim rightly says we need a strong advocacy push for this. Absolutely. Yes. Do we have any other questions for Lauren? Comments as well? Well, we can only agree. Beautifully done, Lauren.
Thank you.
All right. So, are there any further questions, or should we? Oh, see, look at that. There are. So you're talking about vending machines, Alice. Excellent. Well, thank you so much, Lauren. We will move on, and we have another testimonial for you all. So thanks a lot, Lauren, and let's see the testimonial.
I'm 68 years old, and I've been living with HIV for 35 years. When I was first diagnosed, there was no treatment for people with HIV, and I had no hope. I learned about and enrolled in an early HIV clinical study. It didn't work for me, but it showed me that there was research into HIV, and I've had hope. In 1995, I started protease inhibitors. Adherence was difficult, and there were bad side effects, but it was a game changer. I stopped going to my friends' funerals and started going to their birthday celebrations. HIV research has given us treatments that make living with HIV manageable, but that's only true for some people. We need to continue to fund and to fight for HIV research. We need treatments that are affordable, available, and accessible for everyone. We need HIV research. We need an HIV cure. Thank you.